Thanks. I'm Robert Dimeff from Dallas, Texas. I'm representing the American Medical Society of Sports Medicine. We're a primary care sports medicine group, 4,000 members, the largest in the world. It's been around for about 30 years now, and I'm a past president, and they asked me to give a presentation. So my bias on this is I'm a primary care sports medicine physician, so I don't deal with cancer patients per se, some of the palliative medicine. So my bias towards this is going to be towards call it our athletic aging population. So with that, my talk, it's in different orders, is going to very much mirror what Dr. Carr said this morning. I agree almost 100% with what he said. So when I look at sports medicine injuries, we talk about traumatic injuries. Those are the things that get the press. That's not what we deal with primarily. It's really overuse injuries. It's these repetitive stress injuries, arthritis and tendinopathies and so on and so forth that really lead to the chronic pain issues. We talked about evidence-based medicine earlier today, and Guyette really outlined this nicely in 1990, but this is something I always teach the medical students, that Sackett's description, I think, is the most appropriate, and we sometimes forget this. We think evidence-based medicine is randomized controlled trials, double-blind crossover design, but it's really the conscientious, explicit, and judicious use of the current best evidence to take care of the patients. So this is the Venn diagram I use when talking with people about evidence-based medicine. It's this overlap of the clinician's experience, the best external evidence we have, and very importantly, the patient values and expectations. In this Venn diagram, the patient is the most important person. I think we've heard that today over and over again. Individualized medicine, focus on that patient, take the evidence you have for group population and apply it to get your best patient care. So one of the things we're losing in medicine, in sports medicine as well, as the art of medicine, is the art of making a good diagnosis by history and physical, relying on laboratory tests, advanced imaging studies that show a lot of things that are irrelevant for patient care. And so we are losing that touch of the physician, which is a big problem, I think, moving forward. So when it comes to looking at these injuries, we know that there's lots of things that generate pain. We've talked about this ad nauseum today, the myofascial pain, arthritic, nerve entrapment, neuropathies, et cetera. But what's happened in my field is we've gone from taking care of pain to really trying to make the tissue more normal. And what we always focus on, at least from a primary care standpoint, is obviously things non-operative, but least invasive, least expensive, least risk treatment. And I save the caveat except for the pros, because when you're dealing with a player who makes $100,000 a game or $2 million a game, you're not really worrying about expense, and so you don't care about randomized controlled trials. You talk about getting that player on the field today. The other thing that's important, we talked about placebo effect, which I'm a big believer in placebo effect, very well studied. 20 to 50% of our outcomes from studies are placebo effect is the benefit. But when you look at things that are painful, when you look at things that are invasive, and you look at things that are expensive, they're more likely to have a positive placebo effect. So the more we charge for these compounded drugs, the better it has to work, right? So what are some treatments that I look at as a primary care physician? I'm not going to go through all these, but just conceptually, rehab is really important when we talk about this. Physical therapy, exercise, modifying your activity is the single most important thing that I prescribe for patients every day. Exercise is medicine. If you don't exercise, you're not going to get well. I don't care what your chronic pain situation is. Lots of topical measures, heat, ice, all these modalities that may help a little bit. Sometimes they put drugs in there, so on and so forth. I want to point out the manual therapy. We've touched upon this today. Chiropractic care, muscle activation therapy, active release techniques, massotherapy, all these things are beneficial. The human touch is so powerful in healing that physicians who don't touch their patients do not have the same outcome as those who do examine their patients and touch their patients. Diet and supplements. If you're not on an anti-inflammatory diet, I have no evidence to prove it, but I think you're going to have more pain. So that chronic pain patient person should be on an anti-inflammatory type of diet. Lots of injections we do, all the stem cell issues, which obviously we're having some heated debates about, but all that stuff is changing the way I practice medicine. The tail end here, cognitive behavioral therapy and psychology, I'm a big proponent of these things. CBT is really powerful for getting people to heal their problems in their life in general. And don't discount prayer. I always put this in my talks about care. Prayer is a really powerful tool for patients. I don't care who your higher power is, but if you pray that you are going to get better from your disorder and have a positive outlook, you will have improvement. That's been shown in studies. Also, if your church prays for you, you will get more powerful benefit, and that's been shown in studies as well. Now, if the church doesn't pray for you, but you think they are, it still has that powerful benefit. It does. So medications, briefly, right? So we've gone through this. I'm not going to talk about administration in classes. We've gone through all this. Topicals are what we're focusing on today. There's a lot of over-the-counter things that are out there. You know, these things help. They work for patients. They're relatively inexpensive, $20 to $50 for a month's supply. We've talked about Zostrix, topical NSAIDs, which clearly work. Are people in the room here familiar with Trameal cream? Thank you. Okay, so it's been around for 50 years. It's a German product. It's homeopathic. I just started using it in the last couple years, and you know what? It works really well for patients. It's a prescription drug. You need a prescription for it, but it's all homeopathic compounds. And so these sort of things are out there, and you know, you listen to the patients, and if it works, you're more likely as a clinician to provide that for other individuals. So my take on compounding topicals, we've already gone through all the different ingredients. So this is what I guess what I'm supposed to focus on in 2 minutes is my personal use. So when I started, I worked at the Cleveland Clinic for 20 years as the sports medicine director there. When I first started after my fellowship, I had a compounding pharmacy nearby, and it was great. The guy was wonderful to work with, just like the individuals on this panel, telling me what to do. I didn't know what I was doing. Telling me what to do, how to prescribe it, what percentage. It was very, very helpful. But then all these other tools came about that helped me in taking care of patients' care, and the expense of that sort of negated me using it, so I sort of stopped using those over the course of about a decade or so. But I have used them in the past. I certainly think it's worth a shot. Now, here's what we've talked about in the last hour or so. Physicians don't know how to prescribe these things. We rely on industry to make recommendations with little, as somebody's pointed out, virtually no evidence. This is a picture of 20 of the 12 founders of the American Medical Society for Sports Medicine. I'm member 22, so that kind of dates me. I was the second member. But anyway, if you ask these individuals, what do you use for compounding pharmacy drug, they would have no idea. And I could tell you 99% of my colleagues in my society would not know how to write a prescription for this, but the patient's asking us to do that, or the pharmacist is asking us to do this. So there's a huge, huge disconnect there. We talked earlier about education. Obviously, it's very critical. I don't know that the physicians are going to want to take the time unless they're really dedicated to figuring out what to use when, because this stuff is so complicated that we're doing. So do they work? I think so. Are they efficacious? Are they less than, equal, or better than other delivery systems? We've looked at this study. We've talked about this a little bit. I'll just point my bias towards this. Obviously, it didn't show great improvement, but a couple things, again, when we look at the literature, they were looking at a decrease in pain of 2 on that scale of 1 to 10. There's nothing written in stone about that. If your pain level improves by 1 and your pain goes from a 3 to a 2, that's pretty significant improvement. So I don't discount that because they use that minimally clinically relevant number of 20 on the scale of 1 to 100. And then 36% versus 28%. So the placebo group, 28% had improvement versus 36. If you're in that 8%, you know what? That's a benefit to you. So I don't discount this and say it goes, boy, these drugs don't really work in this situation. I still think there's some value there, even though they basically said they wouldn't recommend routine use. I took this case out, but then I put it back in after the last talk. So this was a patient I saw Friday, my last patient of the day, 56-year-old female. I got a call from the NHL. This is a friend of somebody high up in the NHL who's had lateral ankle pain for a year, 57-year-old female. 1 year, about a month of pain, saw an orthopedic surgeon, gave her a cortisone shot, did an MRI scan, said, oh, you got a tear of your peroneal tendons, operates on her, she's casted, she's no better, she's going through rehab, started giving her steroid injection, that didn't work, really not any better, and so he prescribed an anti-inflammatory combination cream. She didn't have any idea what it was. It didn't work, but they kept sending it to her every month, and she kept throwing it away. She said, not working. I'm like, why are they sending it to me, right? This is the disconnect in our healthcare system. So I just injected her, because I was trying to figure out the diagnosis, I injected her peroneal tendons under ultrasound guidance just with saline and a little bit of anesthetic, and her pain's 100% better. So the problem was not an inflammatory disorder, it was a connective tissue, adherence, scar tissue type of issue. So no one took the time to really examine her and listen to what she was complaining about. So then she sent me a text and said, hey, she said I could use her name. So finally she said, this is what they prescribed. So we were talking about cost. So lidocaine, prilocaine, diclofenac, and florandenol, which is a steroid. And then basically she said she wasn't sure how much they charge, and so she just texted me this morning and said, her ankle it's a little sore, but it feels better. But here's the cost. We asked about cost. So this is $290 for her drug, and she was throwing it away every month. Okay. So anyway, I would say application method is therapeutic. I've focused on touch. I think that's really critical. Somebody talked about, is it more important that the provider puts it on or the person puts it on themselves? I think a healthcare provider putting it on is more effective than doing it themselves, but just the fact of massaging the area is helpful. Is it safer than other delivery systems? I think it probably is. I'm not going to go through these. We've talked about all these ad nauseum. Is it less expensive? I would argue that it's probably not. And I have found over the course of my career that these really aren't a whole lot better than any of the other topical agents out there. So what's happened over the course of time, namely because of the efficacy or lack of significant efficacy and the expense, I really have curtailed my use, and I don't really use them at all. So anyway, I thank you for the attention and the invitation. Thanks.